a person asked about wearing a health band, you know, or a medic van, you know, alert. We do have a little card that is something that MPN patients can carry with them. And in fact, I just dropped it, but it's just a little, like a business card. And on the card, you have, you know, that you have a blood cancer, and you tell what kind it is, who your hematologist is with a phone number, and that, you know, if you need any kind of treatment to please contact that person. And so anybody that needs that, please let us know and we will send it to you ASAP. So for you, Dr. Couri, what about couples? How can both men and women overcome some of the things, you know, as a female with an MPN, how can I help my husband or partner to be more involved?
Yeah, I think the most important thing is just communication, just, you know, making sure that your partner realizes what is going on, making your partner an active part of the you know, of the situation, so that in terms of side effects of medications, or, you know, mental, the impact that that the MPN may be having on your mental health, what's going through your mind, just keeping your partner in the loop, and being patient with each other, just, you know, trying to realize that this is a marathon, right? It's not a sprint. We have, you know, MPN patients live with their disease for a long time. And so it's a way for couples to, you know, tackle this together, but respectfully of each other, because chances are your partner's having some sexual problems too, right? I mean, it's not always just us. So it's they may not admit it, but, you know, again, just it's a serious problem, but be lighthearted about it, and realize there's always a way. There's always a way to make it better.
Thank you. You can all show your screen again and leave your mics on, because it's really kind of a panel discussion, because we've got lots of different questions here. Okay, this one is for whatever physician would like to answer. How often should those of us that are JAK2 positive have a cardiac evaluation, assuming there are no other cardiac issues? I'll ask Dr. Ritchie actually here.
So, you know, I think that all of you hopefully have a primary care physician who's following you in addition to your MPN doctor. Although we do a lot of basic care for you, it's really important that you have a primary care doctor, and that primary care doctor, every time that they see you, should be evaluating your cardiac risk factors. You should be having fasting lipids, they should be checking your glucose, they should be checking your vitamin D, they should be doing an EKG if you're over a certain age. And this is sort of the first step. And you also need to report to any of your doctors if you're having something unusual. If you've been able to run, you know, 3 miles a day, and all of a sudden you can't, for whatever reason, that you're short of breath, or you're unable to do the things that you've normally been able to do, or you've had funny feelings like chest pain or jaw pain that, you know, have lasted for a few minutes or half a minute and gone away, or you suddenly had a vision change that went away, all of these things you have to report to your doctor. You can't keep them within yourself, and we can't read your minds. So you have to be able to tell us what's happened to you. You know, based on what we hear and what your primary care doctor discovers, it may be necessary for you to see a cardiologist. And there are many different kinds of cardiologists in this world now too. They are specialized just like we are in oncology. So there are preventative cardiologists that we often send patients to who we believe are at high risk of cardiovascular event. And they really modify and special tune your blood pressure, your cholesterol, and all of these things. And there's a whole field of cardiology, which is preventative cardiology. If you're actually reporting to us a symptom that we find worrisome, that maybe you have been having episodes which are warning signs for a cardiovascular event, we may send you to a cardiologist, hoping that you have a stress test, that you have, you know, an actual cardiac evaluation. And so that really depends on your level of risk, and certainly what your primary care doctor and your MPN doctor find out about you. In general, as we become more mature and we, age up into our 60s, the likelihood is higher that we'll need to have a cardiologist follow us. When you're younger, we really listen very carefully to what your symptoms are and what you report to us and what we see in your laboratory data.
And Kristen or any of you, can you take aspirin while you're on a blood thinner?
Yeah, it's a good question. It depends on the situation. For most of our patients, having kind of combination therapy with both an antiplatelet agent like aspirin or Plavix and a blood thinner like I think Lovenox was in the question, or Coumadin, or any of the other blood thinners that are out there, will increase the risk of things like bleeding events. So it should definitely be on a case-by-case basis. Most of our patients will be on one or the other, either an antiplatelet or a blood thinner, and not necessarily both, but there may be circumstances, individual circumstances where patients may be on both. If there's been, for example, a recent stent and a recent coronary artery stent or lower extremities stent in one of the blood vessels, both may be potentially needed for an overlap period of time at least. But if that's the case, then definitely, sorry, pager, somebody should definitely be paying attention to risk of bleeding events.
And Michele, for those patients who are on hydroxyurea, are there any precautions or measures that they should be aware of when having intercourse, I guess?
No.
Okay.
Yeah, no, that's a good question, but
Yeah.
but there isn't. Yeah.
Does Pegasus or hydroxyurea reduce fatigue? This person is has a CALR mutation exon 9, 60 years old, daily aspirin, platelets are about 850. Either, Ellen?
Well, if I had the magic bullet to treat fatigue, I would be living in some a beachside community at this point in time. Bottom line is that we certainly, fatigue is a major symptom of a myeloproliferative neoplasm, and probably a major symptom of 21st century life. But we try to use medications to try and improve this particular symptom. But as has been mentioned, I think many times over and over again here, that lifestyle modifications, may be the most potent therapy that you can embark on to improve your levels of fatigue. Fatigue is a complicated symptom. It's something which is subjective. So what's fatigue for one person is not fatigue for another. And those are hard symptoms to treat sometimes because it really varies from one person to another. I think that, hopefully that, there will be more insights into the molecular causes of fatigue and maybe better targets in the future of how we can treat fatigue. But I think a combination of your MPN doctor trying their best, maybe with hydroxyurea, maybe with interferon, maybe with a study drug to actually treat your underlying disease, and you taking some initiative on lifestyle changes, embarking on exercise and sort of moments to enjoy your life, that you may improve this symptom, by those sorts of endeavors.
And I think Dr. Mesa mentioned this, and it's been mentioned throughout this program, that the things we can control, take charge of those. And we hear it all the time, and sometimes we forget about that, but we do have some control. And the next question is, how can I lower inflammation? And I just want to say, Dr. Couri, I have been trying to maintain an anti-inflammatory diet and for quite a while now. And it's interesting how you just start to really love this food that, is right there before you. And it's not so outrageously expensive. It doesn't need to change drastically, but when Dr. Couri, do you want to, maybe relate to the patients here that, how the anti-inflammatory diet helped you with your MPN?
Yeah, I'm not saying that diet is, the end all be all for getting rid of inflammation, but, diet has a significant impact, I believe, on our levels of inflammation. And I think that because I personally, if you want to know like how it impacted me, I felt that going into my transplant and navigating my transplant and healing from my transplant was all improved on because of my lifestyle before I had the transplant. So I have tried to eat an anti-inflammatory diet for my entire adult life. And so I think that it's never too late to start. If you've never done that before, tomorrow's a great day to start. It's never too late to make some changes in your health that could potentially help you feel better. And eating is just a fundamental way to do that. And I think that we, unfortunately, patients are bombarded by all these different diets and ways to eat. And, is it paleo? Should we be eating paleo? Should we be eating the blood type diet? Should we be eating an anti-inflammatory diet? Or, should we be intermittently fasting? Or, I mean, they're just bombarded. And the best thing I can say is just everything in moderation. Start with a Mediterranean style diet and then go from there, because that diet truly has been tried and true in terms of the evidence in the medical literature. And I think that it's feasible for most patients. And like you said, Anne, sometimes it can involve a little bit more cost, but beans are cheap. I mean, there are lots of ways. We just have to educate our patients on how to do it, in a way that meets them where they are.
Okay, so for Dr. Ritchie, we know that Dr. Fleischman has done a lot of studies on inflammation. So we know a patient that started taking antibiotics, and the antibiotics basically he didn't go in a remission, but he started feeling better, and his numbers were coming down, they were doing better. I'm not suggesting people take antibiotics. I'm just asking your opinion, how else medically, if we can't do it with diet and exercise and so on, but what other issues surround inflammation? Because it seems like it's a pretty big topic.
Well, I'm definitely not a fan of taking antibiotics on a regular basis to improve inflammation.
Right.
And in fact, it may have a counter effect to that, to inflammation. And you also make yourself resistant to antibiotics. So God help you if you ever got really, really sick and you needed antibiotics, we might not have one that would work for you. Inflammation, there are drugs which are meant to treat inflammation, and they're used a lot in other diseases which have similarities, like autoimmune diseases. They give patients steroids, or they give patients drugs that really depress the immune system. But there are a lot of really bad side effects to those drugs, and they're not something that people should take on a regular basis. You can get infections as a result of being on those drugs. So you need a little bit of inflammation. You need to be able to fight infection, but you don't want to have more than needed in inflammation. And again, this is one of those things that you kind of have to take control of yourself from the data that we have thus far. And diet is one way, but I also think exercise is another. There's a lot of demonstrable evidence that regular exercise can decrease your levels of inflammation and of excess inflammation. So it's making that particular commitment, not only to eating well, but to actually to exercising every day. The other is don't smoke. Don't do things that are also going to cause an inflammatory reaction in your body. Don't take drugs that you're not supposed to take. And don't drink too much. Don't put things into yourself that are going to cause your body to react in a negative way, which is with inflammation. Smoking is really bad. I mean, I don't know how to say this, I could say it. I say it every day to somebody that this is the case. And, you really Vaping is bad too. All these things are bad. Try not to do these things. And I think that's a way that you can help control inflammation.
And we have a few patients that are using medical marijuana, which I'm not going to get into that discussion, except to say that, I've read papers that, anytime you ingest anything in your lungs, that's not really a good thing, And so, I know there are other ways to get that, edibles and so on, but, I agree with you wholeheartedly. I just think, it always saddens me when I see people smoking, because I'm sure it's a very difficult addiction to break, but, it also just wreaks havoc on the body, as you said. Okay, so you mentioned immune disorders. Are there any studies or drugs targeted for MPN patients who do have an autoimmune disorder? Kristen or Ellen?
They often dovetail, right, in some respects. So, if you have rheumatoid arthritis and you have an NPN, drugs like ruxolitinib, there's a drug called Xeljanz, which is very closely related to ruxolitinib, which is used to treat certain autoimmune disorders. Prednisone is used in myeloproliferative diseases. Sometimes it's also used in autoimmune disorders. That the idea or central idea in both of these diseases is to decrease the level of inflammation. But of course, when you decrease the level of inflammation, you also increase the risk of infection. So, that's always the balance that we are trying to take. I think if you have a rheumatologic disease and a myeloproliferative disease, the most important thing that you can do is choose a rheumatologist who will talk to your oncologist and an oncologist who will talk to your rheumatologist. So the two doctors together can come up with a plan that they're both satisfied with to treat your disease. The worst situation for you is to have some doctor that won't talk to another doctor and come up with a final plan for you, where you're both doctors are working in a silo. That is not a good situation for a patient. You need to have doctors who are communicating with each other to find the best solution for you.
And that is, I hate to say it, but that is a pervasive problem that the physicians, all the specialists, they're not sharing information. And, I remember talking about this years ago when I was working in breast cancer and prostate cancer. And it was evident then. It's across the board. It just happens. But that's why when someone was saying you have to be your own advocate, and of course we're here, but we can't be with you every second. But moving on, is combining anagrelide and HU at low dose a good choice for low risk MF patients with high platelets? Kristen?
It could be, depending on the individual circumstance. I think, one nice thing about where we are in this field right now is we do have so many tools in our toolkit to be able to use for various different situations right now, different symptoms, different constellations of blood count abnormalities. And we really have the tools to be able to personalize therapy to individuals. But I do think that also complicates life a little bit. This is where kind of the art of medicine comes in more than the science. And sometimes we do run into a situation where we're trying to use just one medication to control blood counts or symptoms, and we get up to a dose where we're maybe doing a good job at controlling one thing, but then causing another problem at the same time. And it does sometimes work out better for some individuals to be on low doses of two different things to prevent side effects from either one, rather than being on a higher dose of one individual medication. So I will say, as a kind of a personal point of practice, I don't, and that was 3 Ps. I don't usually use a whole lot of anagrelide these days. I think it's not the most, in my experience, not the most tolerable medication out there. It has a lot of cardiovascular side effects, heart failure, arrhythmias, dizziness, those kinds of things. But there are certainly people that tolerate it, especially at low doses. And sometimes it does take a little bit of a kind of going off the cookbook approach to find something that's going to work perfectly for you. And if that combination is something that is keeping your blood counts in check, keeping your symptoms in check, and keeping things stable overall, I think it might not be an unreasonable approach. It's a little off the standard, but I think I can certainly see where that would be the case.
We have time for 2 more questions, and then just to let the audience know that we will be back next month or in October and focus on PV and ET separately at those 2 events. And then in November, we're going to talk to Vietnam veterans who were exposed to Agent Orange, who have MPNs, and to MF patients. And so just so people know that their questions are very important, and we'll email and try to get their answers, the answers for them as we go. But 2 more questions. One, can someone with ET have epidural steroid injections for back and neck pain? And should coagulation studies be done first to see if platelets clot? Ellen?
So, that's another one where there's lots of particular points of patient information, so I can keep up with Dr. Pettit. So if your platelet counts is well controlled and you are not on anticoagulation, many times it's up to the actual person doing the procedure whether they feel you need a coagulation test or not. And they're going to look at your MRI of your back, and they're going to determine where those injections are going to go. And, that sort of allows them to make an educated decision. It's always incredibly important to respect the person doing the procedure. The person doing the procedure, not your other doctors, want to make sure you have the best outcome, and they want to do it safely. So I may not always agree with what the person who is doing a procedure wants to have done prior, but I always respect that they feel they need that information to do their job. If your platelet count is really, really high, over 1 million, and you are not well controlled, it may be that you have something called acquired von Willebrand's disease, which causes you to have a bleeding problem. So in that instance, I would be very hesitant to go forward, with a procedure that would be potentially close to the spinal cord without a lot more, investigation of, whether you would have this bleeding problem and potentially looking at your coagulation. So it's on a spectrum. If you're on anticoagulation, it may be that the doctor doing the procedure will tell you not to take anticoagulative medications before they do the procedure. That being said, if you have intolerable back pain and that is what has been prescribed to you, it often can be a very, very successful procedure for people. And that again, this is another instance where the person doing the procedure talking to your hematologist may come up with the very best plan of all as to how to make sure that the procedure goes forward safely.
So in wrapping up, if I could just hear from, first of all, we've got to address this very quickly, and that is COVID vaccine, COVID booster, flu shot. We've had several of these events over the last year, and the consensus is definitely get all of it, get it all, and including the booster shot. And I'm going to assume we all agree with that. Is that correct?
Yes. I mean, as you can see, no one really knows what the right thing to do is. This morning, the head of the CDC overruled her own advisors on what they recommended for the booster shot. So when you see that degree of disarray, really at the very, very top, you realize that no one really knows the answer. Exactly. While they're offering booster shots, and before they've decided that they're not going to offer them anymore, if you have the opportunity, go get your booster shot. Because they may make a decision next week. Yeah. All don't need them, and they're not going to be available.
Right. But I, as I said, make sure you're getting the vaccine for sure, whether you get the booster or not, get the vaccine. And, my physician said, just wait a week to get the flu shot, which I did, So may I just go to each of you very quickly and, just give us a few sentences about what you like Michele, you had the transplant, back to work, God love you. And, is there any wisdom you'd like to impart to our audience?
Yeah, the wisdom that I have, it was 10 months ago that I had my transplant. And the wisdom that I would say to patients facing the transplant, as you can maybe tell, I'm a huge Notre Dame fan. Sorry, Kristen, the Michigan Notre Dame rivalry, but
Big time.
Lou Holtz once said 3 things, and I carried this with me into my transplant journey. One was trust. You have to trust your team who's taking care of you. Find the team that you absolutely trust with your life, because ultimately they are going to be in charge of it, and never look back. Once you make that decision and they have recommended that you have a transplant, find your team, trust them. The second is commitment. He said, make the commitment. And it's not just the commitment to get through the transplant, the immediate, month in the hospital, month plus in the hospital, and then the first 100 days. It's the commitment that comes each and every day following the transplant, because your life changes in so many ways. In a lot of ways good. It's not always bad, but make that commitment to yourself, to your team that's fighting for you, your transplant team, and stick to it. And then third, love yourself enough to get through this, to do what you need to do to navigate the transplant journey, and love the people that are taking care of you, because it is amazing, the talent that is out there, and the gratitude that I have for transplant teams and transplant physicians and everyone taking care of MPN patients. But don't let fear be your guide into a transplant. It is overwhelming, but if you arm yourself with those things, you can get through it. If I can get through it, anybody can.
Thank you. Kristen?
Oh, that was such a nice answer. I want to play that back every morning before I go to work. That was really nice. I would say, from my standpoint, the thing that I'll say is that I've been in this field for not as long as a lot of the panelists so far. I finished my training 4 or 5 years ago now, and have been focusing on MPN since then. And I'll say there are a few things that really drew me to this field. First of all, is the close relationships that we can really, as practitioners, develop with our patients and their families going through this whole journey is one big thing. And the other thing is just scientifically how quickly things are moving in this field. And I've always been really interested in pharmacology, really interested in drug development. I think one of the most exciting things is early clinical trials, when we're just starting to test a new promising treatment in humans and seeing how it's going to work and what's going to happen. I think that's so exciting. And that's one of the reasons I chose MPNs, because there's so much happening in this field right now. And that, I think, sense of hope and optimism has just grown and grown over the last couple of years. And I think it's just going to continue to really blossom. And we're going to see some really, really great new treatment options coming out over the next couple of years. So I think there's a lot of reason for hope, and keep your heads up. We're talking a lot about lifestyle interventions. I know that, but I think we're going to have more medications and more other things to talk about, before too long.
Ellen?
No, I'm third after 2 actually quite excellent discussions here. I think that I've been in this field now for 15 years, and at the very beginning, in my toolbox was like hydroxyurea and a phlebotomy. There wasn't a lot that was out there, but I've always enjoyed being in this field, even when I had few tools, because of really the personal relationships that you can have with patients and the way that you can assist them as they go through their treatments. It is astounding to me how many new drugs we have in development for myeloproliferative diseases. And not all of them are going to work, but out of this, I think we're going to have a lot of new drugs, and we're going to learn about combining drugs in such a way that I think we can really improve the lives of our patients. And maybe we can even get them into remissions, which would be incredibly wonderful. So we don't have to offer transplant as the only really curative option. I think it's an exciting time to be a physician in this field. And I also think, as a patient, that something is going to happen to you no matter what in your life. You're going to get something. Life has the way of throwing some health problem your way. And being at this moment with a myeloproliferative disease, there's more information than ever before about things you can do personally to take charge of your own disease. And we have all these new medications that we can add. So I think that it's a better time than any time before to be an MPN patient.